Hello, everybody. Thank you to LAHRS organizing team for inviting me to give you this lecture today with you. And we're going to talk a little bit about handling non-infected leads, extract or to abandon. It is a very interesting topic because there is a lot of controversy between abandon and lead extraction in non-infected leads. But the increase in the number of cardiac implanted devices and the increase in the number of complications that involve leads is more important in each day. New and improved tools to extract are available so we can be more effective and safe. So there are arguments against lead abandonment and arguments against lead extraction. There are several reasons for extracting. We can extract because a lead failed, because there's a recall on that lead, because there are a number of previously abandoned leads that we think they might get complicated because of infection, that it's a mandatory indication for lead extraction, vascular occlusion, device downgrade or upgrade, etc. What we don't want to see or we don't like to see is x-rays like this in which we can see a patient with functioning pacemaker leads that required an upgrade to a CRT, and now he has 5 leads in the superior vena cava, and the leads that were abandoned are cut. So what can we do and what can we expect in order to avoid these kind of problems or to take a better decision? Infection is a mandatory indication for lead extraction, and I'm not gonna go into details to these. If we don't extract, death and recurrence is very high. Whether if we extract the whole system, recurrence is very low and patients tend to do much better. So infection is not an issue. But what about abandoning leads in patients that don't have infection? Well, in this series, that it was a retrospective series some 20 years ago, they analyzed 78 patients around age 63 with 3 to 5 years follow-up with average conditions related to patients that are going to receive an ICD. And what they saw is that the number of abandoned leads per patient that was going to go to for a defibrillator was around 1.5 leads abandoned. Few patients had 2 abandoned leads, or very few patients had more than 2 abandoned leads. These were from different brands and types and different locations. And the reasons for abandonment were most frequently oversensing or inappropriate shocks or other lead failures. Other indications as high DFT were very much more or less frequent. And what this group saw is that lead abandon apparently did not affect outcome on the long run, and apparently was safe to abandon leads in patients that were going to receive a new device. But now, what happens if we analyze patients that come with an infected lead that requires indication and that has previously abandoned lead compared to that patient that didn't have a previously abandoned lead? And this paper shows nicely how there's a higher incidence of infection in patients with previously abandoned leads, and that abandonment probably will reduce acute complications, but probably on the long run, especially if that lead gets infected, will have a worse outcome. And that's what they studied. So they made 2 groups, one group of patients with abandoned lead, the other group without abandoned leads. Clinical characteristics were very similar among groups. And what they saw is that procedure duration, fluoroscopy time, were higher in the group with abandoned leads. The need for special tools were higher also in previously abandoned leads, and failure to achieve endpoint and lead material retention was higher in patients with previously abandoned leads, but also and worrisome complications. So previously abandoned leads complicate lead extraction in patients with infection. Vegetations tend to be bigger and more frequent in more frequently found in the abandoned leads. And abandoned leads are associated with more complex procedures with lower success rate and higher complications. So why not to extract when we don't have these kind of complications? In this other paper, they saw the procedural outcomes on the long run in patients that will require lead extraction for any indication and that had an abandoned lead. So it's also a retrospective series on Emory patients from 2007 to 2016, and patients were group in two groups. Group one had a previously abandoned lead. Group two didn't have a previously abandoned lead. I want to emphasize that in group one, infection was the indication more frequently seen in patients with previously abandoned leads uh, and very low percentage of lead malfunction. Whether in group two that didn't have an abandoned lead, the most frequent indication was lead malfunction, not so much for infection. So this is important, and we can see difference in the behavior of the groups. Uh, on the long run, apparently there were not differences in cumulative proportion of surviving in patients in group one and group two, but group one that had previously abandoned lead have higher incidence for femoral rescue approach, and procedural success was very good, but probably they had more difficulty during the procedure, and it was a more complex procedure for extraction. But on the follow-up, patients did good. The problem is what we when we saw this report published from the National Cardiovascular Data Registry, in which is the biggest database on lead extraction and lead abandonment. They almost had 20,000 patients with lead abandonment and lead extraction, 15,000 patients. After matching 12,000 patients, around 12,000 patients in each group with similar characteristics and similar clinical characteristics. And what they saw is that in the lead extraction group, there were higher rates of in-hospital death related to procedural events or any intra or post-operative events in the lead extraction group. And this was very significant. And also major complications and minor complications were around the same between groups, but when taken all into account, also more frequent in the lead explantation group. After analyzing after 6 months after lead extraction or lead abandon, apparently there were no more complications in the lead abandonment group compared with the lead explanted group. So a lot of questions raising there, and mortality, although not non-significant, seemed to be a little bit higher on the lead explantation group. So they concluded that patients with lead extraction had higher complication rates during in-hospital stay, and at 1 year, mortality was significantly, it was non-significantly increased in the lead extraction group, um, but no apparent other complications were seen in the lead abandoned group. So what if lead extraction is done in a high volume center with a lot of experienced operators? Where in this group they tried to analyze that and saw that if you were going to extract, it was better to have a very experienced operator if you're going to make the extraction. And with that, you could see that even in high risk populations, these are patients almost all with ICDs and CRTDs, very few patients with pacemakers. They had uh, no increase in acute complications and no increase in mortality or complications at the follow up compared with the group with abandoned leads. So favors that if you're going to extract, you need to extract with an experienced operator. And also in this other paper from the Cleveland Clinic, what they saw is that in a high center, in a high volume center for lead extraction, you could do very effectively, almost 96, 97% of clinical success. You can do lead extraction safely with very few cases with retained material and with low percentage of complications. So lead extraction in a high volume center is probably a good way to go and safe and does not seem to affect comparing with abandoned leads. And now, really, we have better tools than we used to have years ago when we have simple traction and walking stylets. Now we have femoral snare, laser sheets, and mechanical rotational sheets that, in our experience, are very, very effective and has changed that curve of lead extraction to higher rates of efficacy and very few complications, as we saw also in our series with the evolution um, mechanical rotational extractor, very high levels of success, very few complications compared with the result of this meta-analysis that I just showed you, comparing radio frequency laser, femoral laser, or guides or mechanical sheets. Guidelines now give us more light into which patients need to be extracted. For example, if that patient is going to receive a stent in the vasculature because of an occlusion and has a lead, you need to take that lead before. If you want to remain to keep patency of a vein, you can extract, treating fatal arrhythmias, severe chronic pain. If that abandoned lead interferes with a new implanted device, if you have more than 4 leads in one side or more than 5 leads in their superior vena cava, or you have a venous occlusion, it is reasonable to extract. If you're gonna abandon or extract, you need to be aware of the result you have in your center. You need experienced lab and you need an experienced operator and discuss it uh, widely with your patient. Also, extraction can be recommended in patients whether have thromboembolic events or other problems with superior vena cava stenosis, or are going to have leads that will require extraction in the future. So, for example, in this patient that was a very sick patient in acute heart failure, well, abandon is not contraindicated, but if you're going to leave 5 leads in there, maybe it would be better to lead extract. So, in favors of lead extraction is high volume centers with more than 30 extractions a year, operator experience, younger patients, life expectancy more than a year, high risk of lead infection, upgrades, or where benefit outweighs the risk. But you can abandon in low volume centers with older patients, with multiple comorbidities, with very complex anatomy and unstable patients. Now with CT, you can pre-detect complications, seeing how close to the vessel is the lead, or to another, how close to another lead is that lead that you're going to extract, and predict how difficult it's going to be your procedure, and maybe decide whether to abandon or extract. So, in conclusion, lead extraction is safe, is the treatment of choice for patients with infection, no doubt about it. It's a very useful alternative for managing lead complications other than infection, should not be feared, should be learned, and decision making with the patient analyzing pros and cons is mandatory for non-infected leads in experienced centers, and this is very important. Thank you very much.